Hello everyone. In this lecture, we are going to discuss about lymphadenitis. So basically, lymphadenitis means it's the inflammation of the lymph nodes. Sorry, it is inflammation of lymph nodes. Now, this inflammation can be of acute or it can be chronic inflammation. First, we'll discuss about the acute non-specific lymphadenitis. Okay. But I must tell you that before understanding this topic, we have to know the basics of the lymph nodes, which I have covered in the previous video. So if you have not watched that video, first of all, you have to see that video and then you can understand this topic better. Okay. So first we'll discuss about the acute non-specific lymphadenitis. This happens whenever there is infection or inflammation. Okay. So whenever there is infection or inflammation, this is going to cause acute lymphadenitis. Okay. So basically, if the infection is happening in a particular area, the lymph nodes which are draining that particular area, those lymph nodes will be affected. Okay, at least in the initial phase. Okay, so if there is infection or inflammation in the teeth or tonsil, this is going to affect the cervical group of lymph nodes. Cervical group of lymph nodes. Upper extremity infections will affect the axillary lymph nodes. Lower extremity infections is going to affect inguinal lymph nodes. Acute appendicitis or similar gut infections, that is going to affect the mesenteric lymph nodes. And if the patient has widespread systemic bacterial or viral infection, that is going to cause generalized lymphadenopathy. That is going to cause generalized lymphadenitis. Okay, so it's very simple. Whichever lymph node is draining that particular area, those lymph nodes will be affected. Okay, and if it is a widespread infection, it's a severe bloodstream infection, that is going to cause generalized lymphadenopathy. Morphology, it's a very simple thing. If you have understood inflammation, all the features of acute inflammation you are going to find. So the lymph nodes will be swollen, they will be red, they will be engorged, and also these are tender. These are tender. Okay. And inside the lymph nodes, you are going to find large reactive germinal centers and increased mitotic figures. Okay. Because these lymphocytes in the, especially the B lymphocytes in the lymph node, they'll be activated upon exposure to the antigens, and once they become activated, they will form these reactive germinal centers, and also there will be increased mitotic figures. So mitotic figures are actually, these are the histological findings of a dividing cell. Okay, so whenever you find dividing cells, you can always get the mitotic figures. How exactly it looks like, we'll discuss that in the subsequent slides. Okay, so because the B lymphocytes will be activated and they will start to proliferate and divide more and more, you can find the mitotic figures along with the reactive germinal centers. Also, there will be increased macrophage activity. And if this infection is caused by pyogenic organisms, if it is caused by pyogenic organisms like Staphylococcus aureus, you are going to find increased neutrophils inside the lymph nodes. Okay, there will be increased neutrophils. And also, there can be necrosis. There can be necrosis of the germinal centers. And ultimately, this can result in formation of pus. So you must have studied in the chapter of inflammation. So how do you define pus? So pus is nothing but collection of necrotic materials, edema fluid, and the neutrophils. Okay. So whenever there is an infection due to pyogenic organisms, there will be neutrophilia. It can cause necrosis of the germinal centers, leading to formation of the pus. Okay. And if the pus is encased in a particular area, that is known as abscess. Okay. So if the pus is encased in a particular area, that is known as abscess. And sometimes this lymph node abscess can come onto the skin surface through a connecting channel that is known as sinus. Okay. So sometimes this lymph node abscess, the pus material, can come out of the skin surface through a sinus. Okay, through a sinus. And you can appreciate that the pus is coming out from the skin. Okay, so sometimes this can also happen. And whenever there is abscess formation, the lymph node will become fluctuant. Okay, So this is the clinical sign that you have to remember. Whenever there is abscess formation, the lymph node will become fluctuant. Okay, and healing of this lymph node will happen with scarring. Okay. So once this affected lymph node will start to heal, it will heal by scarring. Okay. So these are the basic concepts that you must have studied in the chapter of inflammation also. So it's a very simple thing. Now we'll discuss more important conditions, that is chronic non-specific lymphadenitis. Okay. Under this heading, we are going to discuss about the follicular hyperplasia. Then we'll discuss about paracortical hyperplasia. Then we'll discuss about sinus histiocytosis. Now, all these things are very easy to understand once you understand the normal lymph node structure. Okay. So let us discuss about the follicular hyperplasia. From this, you can understand there will be hyperplasia of the follicles. So follicles are nothing but the B lymphocyte follicles that you generally find in the cortex of the lymph nodes. Okay, so B cell follicles are found in the cortex of the lymph nodes, and in this condition there will be hyperplasia of those follicles. Okay, so from this you can understand that any condition, any condition that will cause humoral immune response, that is going to cause humoral immune response. B lymphocytes take part in the humoral immune response. Okay, so any condition which activate the humoral immune response, in all those conditions you are going to find the follicular hyperplasia. Okay, and this concept we have already discussed previously. This is the primary follicle. Okay, and this is the secondary follicle, which develops after exposure to the antigen. And I have told you this antigen exposure to the B lymphocytes happens with the help of follicular dendritic cells. Okay, so these follicular dendritic cells, they will hold the antigens which are already bound by the opsonins, and those antigens can be recognized by the B lymphocytes. Now these B lymphocytes will be activated, and they will form the activated B lymphocytes. Okay, and we have discussed that activated B lymphocytes can take the form of centroblasts. Initially, they will take the form of centroblasts, then they will become centrocytes. Okay, how will you identify the centroblast? If you see here, so among centroblasts and centrocytes, centroblasts are larger. Okay, so if you see here, these are the centroblasts. So this is a centroblast. This is also a centroblast. So these are larger cells. They will have nucleus with open chromatin. That means the nucleus, or you can say the cell is active. The cell is active because it has a open chromatin. Okay, open chromatins are easily transcribed. And you will also find the nucleoli which are attached to the nuclear membrane. They are attached to the nuclear membrane. Okay, these are the features of centroblast. These are large cells. These are activated B lymphocytes, which are larger cells, which have nucleus with open chromatin, and you can find the nucleoli, prominent nucleoli, which are near the nuclear membrane. So you can appreciate that these are the nucleoli which are present near the nuclear membrane. Okay, and also these cells, these centroblasts, they will not express the surface immunoglobulins. And slightly more mature cells are the centrocytes. These are the centrocytes. They will have cleaved nucleus, you can say. Actually, they will have cleaved, or you can say twisted or angulated nucleus. And nucleoli are not that prominent. Okay, nucleoli are not that prominent as compared to the centroblast. And of course, they will present the surface immunoglobulins. Okay, so in the germinal center, you are going to find the centroblasts and the centrocytes. Okay, so these are the centroblasts and these are the centrocytes. And you have to remember one thing, that this arrangement of centroblast and centrocytes inside the germinal center, these are polarized. This is polarized. So what do you understand by polarized arrangement? Polarized arrangement means on one side, you are going to find the collection of centroblasts, and on the other side, you are going to find the collection of centrocytes. Okay, as you can see in this image, on this side, on the left side, I have arranged the centroblast, and on the right side, you can appreciate the centrocytes. Okay, you can appreciate the centrocytes. Now, this centroblast rich region is known as the dark zone. So, this is known as the dark zone. And the centrocyte rich region is known as the light zone. Okay. So these dark zone and light zone are based on the presence of centroblasts or centrocytes. Okay. So that means the germinal center is polarized. That means one side you are going to find collection of centroblasts, that is known as dark zone, and on the other side you are going to find collection of centrocytes, which is known as the light zone. Now here you should not be confused with the germinal center and the mantle zone. If you compare the germinal center and the mantle zone, as you all know, this outer darker area is the mantle zone. If you compare with germinal center and mantle zone, the germinal center as a whole is lighter compared to mantle zone. Okay, germinal center is lighter in comparison to the mantle zone. However, inside the germinal center, again we have two zones. One is the dark zone, another one is the light zone. Dark zone is because of the centroblasts, and light zone is because of the centrocytes. Okay. Now, apart from this, as we have discussed previously, in the germinal center, you are also going to find the macrophages, the follicular dendritic cells, and the reticular cells. I have told you that if the centroblast, if the centrocytes, if they express certain receptors which are recognizing the self antigens, those centrocytes, those activated B lymphocytes has to undergo apoptosis. Okay, they have to undergo apoptosis, and those apoptotic materials will be taken up by the macrophages. So if you see the macrophages inside the germinal center, you can appreciate that they have engulfed the apoptotic materials. As you can see here, this is also a macrophage. This is also a macrophage. Now these macrophages which are engulfed the apoptotic materials, these are known as tingible body macrophages. These are known as the tingible body macrophages. Okay. So these are the things you are going to find in a secondary lymphoid follicle. So I'll just repeat it again. So in primary follicle is otherwise known as the inactive follicle or quiescent follicle. These are not exposed to any kind of antigen. Once they're exposed to antigen with the help of follicular dendritic cells, they'll make a germinal center. In the germinal center, you are going to find activated B lymphocytes. These activated B lymphocytes are two types. One is centroblast, which is larger. It has an open nuclear chromatin, and nucleoli, prominent nucleoli, which are attached to the nuclear membrane, and they will not express surface immunoglobulins. And this collection of centroblasts, they will make the dark zone. On the other side, you will find the centrocytes, which are slightly more mature compared to the centroblast. They will have cleaved or twisted or angulated nucleus. The nucleoli are not that prominent, and they will express the surface immunoglobulins. And this collection of centrocytes are known as the light zone. And interspersed in this germinal center, you are going to find some macrophages which have engulfed the apoptotic materials. And those macrophages are known as tingible body macrophages. These are known as tingible body macrophages. Okay. So this is about the secondary follicles. These secondary follicles you are going to find classical in patients with follicular hyperplasia, in cases with follicular hyperplasia. Okay. So if you see the histological image, you can appreciate that this is a secondary lymphoid follicle. Of course, this is a secondary lymphoid follicle. You can appreciate that this is the mantle zone. Okay, so this one is the germinal center. Of course, this entire area is the germinal center, and surrounding the germinal center, you can see there is a darker zone. So this is the mantle zone. This is the mantle zone, of course. And you can also appreciate that inside the germinal center, this area is slightly darker compared to this area. Okay. So this area, which is slightly darker, this is the dark zone. This is the dark zone, which is made up of centroblasts. And this area, which is slightly lighter compared to the dark zone, this is known as the light zone. which is made up of centrocytes. And you can also appreciate that these are polarized. That means on one side, you are finding the centroblast predominantly, and on the other side, you are finding the centrocytes predominantly. That is how they are making the dark zone and the light zone. And in between this, I mean, inside this germinal center, you can appreciate there are some pale areas like this. So these are nothing but the macrophages. These are nothing but the tingible body macrophages. These are tingible body macrophages. Okay, so this is an example for follicular hyperplasia. If you go to the high part, you can appreciate that these are actually centroblasts, and you can appreciate that these are the macrophages. These are the tingible body macrophages, which is containing the apoptotic materials. And you can also appreciate one more thing, like if you see this one, and also this one, these are actually mitotic figures. So actually, mitotic figures, if you have studied, you must have studied in the process of mitosis. So what happens in mitosis, when the cell will try to divide, they have to duplicate their the chromosome materials, the genetic materials, and then those genetic materials, those chromosomes will be separated from each other with the help of these mitotic spindles. Okay. So during the process of mitosis, these kind of cells we are going to find. And this cell, when you see under microscope, it will look something like this. Okay, so this cell, if you see under microscope, it will look something like this. And these are nothing but the mitotic figures. So mitotic figures are basically the dividing cells. Okay, I mean the cells in division. Okay, so any cases with active proliferation and division of the cells, you are going to find the mitotic figures. Okay, so these are all the histological points that you are going to find in patients with follicular hyperplasia. Now, many times follicular hyperplasia is confused with follicular lymphoma. Many times it is confused with follicular lymphoma. Now, what are the points of difference between follicular hyperplasia and follicular lymphoma? The first point is the lymph node architecture. The lymph node architecture is maintained. Lymph node architecture is maintained in follicular hyperplasia. The lymph node architecture is maintained in follicular hyperplasia. That means in follicular hyperplasia, you can clearly distinguish the cortical area, the paracortical area, which is containing the T cells, the medullary area. So all those structures are maintained. So lymph node architectures are maintained. The second point is variation in lymphoid follicles. I mean variation in size and shape of lymphoid follicles. So lymphoid follicles will be of different sizes. Okay, but in follicular lymphoma, you will have similar size lymphoid follicles. Okay, so in follicular hyperplasia, there will be variation in the lymphoid follicular size. In follicular lymphoma, there will be similar kind of lymphoid follicles. And the third point is we are going to find, the mitotic figures. We are going to find the mitotic figures and the tingible body macrophages. Okay, so mitotic figures, tingible body macrophages, these are found in follicular hyperplasia. So all these points, these are found in follicular hyperplasia, and not in follicular lymphoma. Okay, we'll again discuss these points when we will discuss about the follicular lymphoma. But these are the three important points you have to remember. Lymph node architecture is maintained. There will be variation in the lymphoid follicles, and you are going to find mitotic figures, tingible body macrophages in the follicular hyperplasia. What are the causes? As I have told you, any condition that will cause a humoral immune response, in all those conditions, you are going to find a follicular hyperplasia. So classical examples, if you want to remember, the classical examples include rheumatoid arthritis, toxoplasmosis, and early HIV infection. Okay, so these are some of the important causes. Of course, there are so many other causes which can cause follicular hyperplasia. Okay, so this is all about the follicular hyperplasia. Now we'll go to the next morphological variant of chronic non-specific lymphadenitis, that is paracortical hyperplasia. So as you all know, paracortex, it consists of the T lymphocytes. Okay, it consists of T lymphocytes. So any condition which will activate, which will produce a T cell response, in all those conditions, we are going to find a paracortical hyperplasia. And classical example is viral infections. Classical example is viral infections. Okay, so paracortical hyperplasia are classically seen in viral infections, especially the infectious mononucleosis. Infectious mononucleosis. Okay. So what are the morphological points? So now you have to focus on the paracortical area. So this is the paracortex. This is the paracortical area, and you can see in the paracortex we are going to find the activated T lymphocytes. Activated T lymphocytes. Activated T lymphocytes, similar to activated B lymphocytes, this will have a nucleus with open chromatin. Okay, this will have a nucleus with open chromatin and prominent nucleoli. So those things we can also appreciate here. It has a nucleus with open chromatin and it has prominent nucleoli. Okay, so we are going to find activated T lymphocytes. Remember, in this diagram, for the sake of simplification, I have given different color to the T lymphocytes. Okay, so I have given black color to B lymphocytes and green color to T lymphocytes. But in reality, both B lymphocytes and T lymphocytes, they look similar. Okay, so under microscope, it is not possible to differentiate B lymphocytes from T lymphocytes unless you have applied some specific markers. Okay, so the lymphocytes are differentiated under microscope only by applying specific markers. By just looking simply with routine stain, you cannot differentiate the B and T lymphocytes. Okay, this diagram is only for the purpose of simplification. Okay, so you are going to find activated T lymphocytes in the paracortical area. Along with that, you are also going to find some immunoblasts. Like we have discussed for activated B lymphocytes, in activated B lymphocytes, a form of activated B lymphocyte is centroblast. Similarly, a type of activated T lymphocyte is known as immunoblast. Okay, how you identify the immunoblast? Immunoblasts will have a central prominent nucleoli. Okay, this will have a central prominent nucleoli. I have told you in centroblast, the centroblast will have nucleoli which are attached to the nuclear membrane. Okay, but immunoblast will have a nucleoli which is present exactly in the center of the nucleus. Okay, so that is the basic difference between the immunoblast and a centroblast. Okay, so immunoblast is nothing but an activated T lymphocytes, a type of activated T lymphocytes. Okay, so these are the things you are going to find in the paracortical area. And sometimes this paracortical hyperplasia is so much that these T lymphocytes tend to encroach upon the follicular areas, I mean the cortical areas. Okay, so sometimes this paracortical hyperplasia is, I mean, the hyperplasia is so much the activated T lymphocytes will try to encroach upon the B lymphocytes. Okay, so that is why sometimes it is very difficult to differentiate under the microscope. If you see, it is very difficult to differentiate if the paracortical hyperplasia is in an advanced phase. It is very difficult to differentiate whether the reaction, whether the proliferation is confined only to the paracortical area or there is a diffuse B and T cell hyperplasia. Because sometimes the T cell hyperplasia, I mean the T cells, activated T cells can go and encroach upon the cortical or follicular areas. Okay, and I have told you B lymphocytes and T lymphocytes are difficult to differentiate under microscope with routine stain. Okay, so in those conditions, we have to apply the special stains only to differentiate these B and T lymphocytes. And if there is only predominance of the T lymphocytes which are going from the paracortical area to the cortical area, we can tell that this is just a T cell response which is so vigorous that it is encroaching upon the cortical areas. Okay, and also sometimes you can find the dendritic cells. These are not the resident dendritic cells of lymph nodes. These are the migrating dendritic cells. As I have told you previously, these dendritic cells, they will recognize the antigen, they will process the antigen, then they will come to the lymph nodes to the paracortical area, and they'll present the antigen to the T lymphocytes. Okay, so sometimes in this paracortical area, we are going to find these dendritic cells. Okay, apart from this, you are also going to find endothelial cell hyperplasia. Endothelial cell hyperplasia. Now, these endothelial cells are present in both sinusoids, I mean in the sinuses and in the vessels. Sinuses means these sinuses, this we have already discussed, the subcapsular sinuses, the trabecular sinuses, the medullary sinuses. Those sinuses also will have the endothelial cells, and this Vessels will also have endothelial cells. And in this condition of paracortical hyperplasia, we're going to find significant endothelial cell hyperplasia. Okay. And also, this condition is associated with increase in macrophages and eosinophils. Okay. Sometimes these are associated with increase in macrophages and eosinophils. Okay. So this is about the paracortical hyperplasia. Now we'll discuss about the sinus histiocytosis. This condition is otherwise known as reticular hyperplasia. Basically, this condition, sinus histiocytosis, is found in those lymph nodes which are draining cancers, especially the carcinomas. The classical example is carcinoma breast. Okay. So you must have studied in the chapter of neoplasia that carcinomas usually spread through the lymphatics. Okay. So if a lymph node is draining a particular carcinoma, those cancerous cells, those neoplastic cells can enter through these afferent lymphatics and they can go into the sinuses and there will be proliferation of the sinuses. So basically here you are going to find sinus expansion and distortion. Sinus expansion and distortion. This happens because of endothelial cell hyperplasia. I mean, those endothelial cells which are present in the sinuses. So as you can see here, this is a sinus. This is the trabecular, this is the subcapsular sinus, and this one is the trabecular sinus. You can see the sinuses are enlarged, and you can appreciate there is endothelial cell hyperplasia. Along with that, you are going to find increased activated macrophages. Okay, so these are the macrophages. I have told you histiocytes denote the activated macrophages. So this condition, sinus histiocytosis, means increased activated macrophages inside the sinuses. Okay, that is the literal meaning of sinus histiocytosis. Okay, so in this condition is found usually in those lymph nodes which are draining the cancers, especially the carcinomas. In this condition, you are going to find sinusoidal endothelial cell hyperplasia, increased activated macrophages in the sinuses, and all these things is ultimately leading to sinus expansion and distortion. Okay, so this is known as sinus histiocytosis. Now, coming to the overall clinical features of chronic lymphadenitis. Remember, chronic lymphadenitis, in contrast to the acute lymphadenitis, these are usually non-tender. And what are the usual sites you are going to find the chronic lymphadenitis? Usual sites are axillary and inguinal lymph nodes. Because these lymph node groups, they drain a larger area of the larger parts of the body. Okay, so that is why in chronic infections or chronic inflammations, these lymph nodes are usually involved. The last thing is, what is the concept of tertiary lymphoid organs? I have already told you about the primary lymphoid organs like bone marrow, thymus. Then I told you secondary lymphoid organs. These include the lymph nodes, spleen, or the mucosal associated lymphoid tissue. Then what is tertiary lymphoid organs? Now, tertiary lymphoid organs are formed whenever there is chronic immune reaction, which is resulting in accumulation of immune cells in a particular area. Immune cells means the lymphocytes, of course. Or you can say a organized collection of the lymphocytes. Chronic immune reaction, this will cause an organized collection of the lymphocytes, and that is known as the tertiary lymphoid organ. Okay, so that is the tertiary lymphoid organ. This is mediated by a cytokine. And the name of the cytokine is lymphotoxin. If you see some of the examples, in patients with chronic H. pylori infection, you can find gastric mucosal lymphoid accumulation. This will resemble the Peyer's patches. This will resemble the Peyer's patches. This will discuss more when we discuss about the GI pathology. The rheumatoid arthritis, this can make B lymphoid follicles. This can make B lymphoid follicles in the synovium. Okay. Rheumatoid arthritis we'll discuss under the joint pathology section. Okay. So rheumatoid arthritis is a condition which can form B lymphoid follicles in the synovium, and H. pylori is a condition which can cause gastric mucosal lymphoid follicles, which will resemble the Peyer's patches. And all these things, all this formation of tertiary lymphoid organs is mediated by a cytokine that is known as lymphotoxin. Okay, so this is all about the lymphadenitis.